Good evening, good morning, good afternoon, good day. Welcome to another session of the AME Grand Rounds, and I'm going to go ahead and let Dr. Northrup start us off.
Well, let me add my greeting to everyone. Thank you so much for being here. This is sort of a red letter day for us, and I'll let Christy explain why. But we do appreciate the fact you take time out of your busy schedule to sit in with us once a month. So I'm not going to hold a whole lot else. Dr. Wyrick, if you want to wave, and then we'll turn it over to Christy.
Hey there, everybody. Good to see you. Thank you for joining us.
All right, without further ado, all yours, Christy.
Okay, Dr. Fraser, do you want to go ahead and start the slides? Here we go. Okay, next slide, please. Here is our standard "this session is being recorded" slide. No participants will be shown, and I have some great news for everyone this evening. If you weren't on at the first session earlier today, we do have all but one of the past recordings uploaded now to our YouTube playlist. So Gary's going to paste the link that you see on the slide in the chat. You can also find those past Grand Round sessions by opening up your favorite internet browser, searching on YouTube for AME Grand Rounds. And you will find all but I believe the April session and of course the May session. We will make this recording available. It'll probably take 2 or 3 weeks at a minimum to get those uploaded, but you will see the recording appear later. Next slide, please. Some administrivia to talk about. First off, the session will be locked after 10 minutes or once our first speaker starts talking about our topic at hand. What this means that if you lose internet connection, you may be unable to rejoin. If you're in the Zoom right now and you happen to lose your internet connection, you can try sending an email to amenotifications@faa.gov to regain access once the room is locked. And we may be able to readmit you, but just keep in mind that it's locked. All your chat and cameras, those are disabled. We do want you to enter all your questions using the Q&A button at the bottom of your Zoom screen. So if you would take a minute right now and just look at your Zoom, find that Q&A button, and that is where you're going to enter in any questions that you have. We also ask that you would please limit your questions to the topics that are being discussed. We have quite a few FAA staff on here who will be answering those Q&As while we're presenting. And then we'll also allow for some time at the very end to answer questions live as time permits. As part of our accreditation, we do have to disclose if we have any financial relationships or prohibited relationships from any of our speakers. And this is the statement for this session, that we have no prohibited relationships to disclose. Next slide, please. To get CME credit for this session, first and foremost, the most important thing I can tell you is to verify right now that your first and last name are displayed on the Zoom screen. So if you will find yourself in the list of participants, look to the right and find the ellipses and click on that and rename yourself. We do need your full first and last name in order to be able to grant CME. If that is there at the end of the session, you will be able to request that. And also, as a side note, if you're watching this recording at a later date, we are unable to grant CME for watching the recording. This is our celebration, and this is actually a pretty big deal. We have now been doing the Grand Rounds for a full year, and I think that's pretty cool. Starting in fiscal year 24, in other words, from April to October of 2024, we had around 773 AME attendees attend Grand Rounds. And going forward from October till April of this year, we've had over 2,600. So that's over 3,400, I believe. I don't math very well on the fly, but over 3,400 AMEs have attended Grand Rounds. We can't do what we do without you. So thank you for attending. Thank you for being an AME. Next slide. This evening, we're going to do things a little bit different, and we're going to be addressing frequently asked questions. The first set of FAQs we're going to talk about are all about maintaining your designee status. We're going to talk about how you access DMS, AMCS, and DRS. We'll talk about My Access login issues, what to do if your office moves, and also how to certify your staff. Next slide. And then we're also actually going to address some FAQs regarding disease conditions. These are the top conditions that we get questions about. We'll talk about atrial fibrillation, aortic dilation, aortic aneurysm, diabetes and weight loss medications, color vision, only one slide there, I promise, medications, cancer, and verbal authorizations, or as we say in the FAA, verbal auth. And with that, I'm going to go ahead and turn this over to Leah Olson.
Hello, everyone. We just got some questions here lately about our different systems that we use as AMEs. So I just kind of want to go over those with you. Next slide, please. Okay, so these are the websites that you would go to access DMS, AMCS, and DRS. As you know, designee management system is where you're going to manage your designation at. You can find that at designee.faa.gov. The Aerospace Medical Certification Subsystem, or AMCS, you can find at faa.gov/go/AMCS. And of course, that's where you're going to transmit your exams. The Designee Registration System, DRS, that is where you are registering for seminars and training. However, this system is going away as of June 25th. We will have a new system out called DTS. We will bring you all of the important information on how to use that in the next couple of weeks. And you can find that, the DRS system, at av-info.faa.gov/DSGREG/login.aspx. Next page. Next slide. Okay, so all of these systems now use My Access to log in. Everyone should have already registered with My Access. If you've transmitted any exams at all, or if you've logged into DMS lately, you've set up your My Access account. If not, you're going to need to go to the top of the page, and you're going to use the activate an existing external account. Those are for the people that are already AMEs and are being grandfathered in. Each of these accounts must be linked to the same email address. So if you register your My Access account and you go to log into AMCS, but the email address isn't working, you need to contact AMCS and they can help you get that migrated over. Next slide. So if you've ever been locked out or you need to change your password, you can do that at the bottom of the page. You can use the unlock account link or manage My Access account. Next slide. And once you go to those links, this is what it looks like. Gives you the opportunity to change your email address, update your name, change your password, update your authenticators with the multi-factor authenticators. There are a few to choose from if you need to change those. And then once you log out, you'll need to go back into your link to log into the system that you're trying to log into. I believe once you hit log out here, it takes you completely out of the system. Next slide. So for My Access login issues, that would be any of the login issues that you have with any of the three systems. You're going to call the FAA IT Help Desk at 844-322-6948, or you can email them at helpdesk@faa.gov. For any DMS issues, 9-ABS-DMS-AME@FAA.gov. That goes directly to my desk. So for any issues as far as using DMS, I can help you with those. And then for AMCS issues, you can contact them at 405-954-3238 or at amcssupport@faa.gov. And also, if you do not have access to AMCS, your new AME or whatever, or you have new staff members that need accounts, you can contact them at either one of these at the number or at the email address and request AMCS access. They'll send you a form, and it doesn't take but just a few minutes to get you set up. And then the DRS and any training issues that you might have, whether it's issues with MAMARC or registering for a seminar, whatever your training issue is, you can contact the training staff at AME-distance-training@faa.gov. And I will copy and paste all of these addresses over into the chat. So you can copy and paste those from the chat if you need to. Next slide. Okay. Is your clinic moving? Next slide. We need to know where you're going. We need you not to perform any exams at the new location until your regional flight surgeon has approved your new location. And the process to do that is the change designation location link on your home page in DMS. Next slide. That will take you to this page. It gives you the opportunity to add a location, and if you need to remove a location, there will be an additional link underneath this box that says remove location. So you're going to want to make sure that you put in the correct address, and then you hit submit, and that goes directly to your managing specialist desk, and they should be able to work that request for you from there. Next slide. Okay, so we've been getting some questions since we've had a lot of turnover here lately. Who is my managing specialist? So I want to show you how to find that. On your home screen in DMS, under the designee actions, you can click on the action link. Next slide. And a little bit further down the page is the managing specialist. It will list whoever your specialist is. If for some reason you can't find it, you can always give your region a call and they can let you know who that is. Next page. I think that's all I have for you. If you have any questions, I'll answer those in the chat for you. I believe they want to go ahead and go on with the Grand Round session.
So thanks everybody for joining us again for another Grand Rounds. For today, what we're going to do is go over condition frequently asked questions. So thanks to everybody who responded to the survey that AAM 400 sent out a couple of weeks ago. You gave us a lot of good information, a lot of material that you wanted us to cover. So what we're going to go over today are some of what was on that list. One of the big topics that we received questions on was AFib. So a question that we get is, what are the aeromedical risks? Stroke, blood clots, heart failure. Another running theme throughout the survey was, where do I find information? How do I navigate the guide? Where do I find the right info? So we're going to touch on those as we cover different conditions. If you're in the AME guide, you can search for flutter or fib. For this specific case, we have a 77-year-old third class, history of AFib, diabetes, sleep apnea, and hypertension. You're seeing them for the first time for a third class exam. He's doing well on Pradaxa. He had his cardiologist complete an AFib status summary. He's got a Holter that's coming up next month. So with just looking at the AFib information, what do? The first thing is go find the information on AFib. So what you see here is the PDF version of the AME guide. If you hit Control F, you can open up a search box. You see the search box is in the top right corner. I type in Flutter because I know Flutter is the most common word compared to fibrillation in the guide. So I type in flutter to find it faster. And what you will get is the disposition table. If you like to use the online version instead, you can use your favorite search engine, Google, Bing, there's a bunch of them. In the search bar, type in FAA, AME Guide. You need to put the word dispo table or disposition table, and then whatever condition you're looking for. If you put the word disposition table, it will bring you to the dispo table. If you just put fibrillation or flutter or sleep apnea, you could get any of the multiple documents for that condition. So if you're online, just use FAA, AME Guide, dispo table or disposition table, and then the condition. So where do AMEs have trouble? If it's an initial presentation for AFib, the first thing is just finding the information and making sure you're using the correct row of the dispo table. Also finding and using the status summary for AFib. We'll talk a little bit about the CHADS 2 VASC score. Remember, anyone that has a 2 or higher has to be on anticoagulation. And anticoagulation means a NOAC, DOAC, warfarin, or an LAA occluder. So what you see on your screen now is row C of the dispo table for AFib. Our 77-year-old third class first time with AFib presenting to your office falls into row C. If you go to the second column, that's the evaluation data column, tells you and the pilot what information they're going to have to provide for potential certification. So the first item is the AFib, and it's non-valvular AFib status summary. We'll talk about the status summary in a second, but remember the idea of a status summary is to hone in on the information that we need to make the safety decision. You know as well as I do, when you're reading through charts all day long, different charts read in different ways. Sometimes it takes a lot of reading to find what you're actually looking for. The status summaries that we've created hone in on what we really need to make the safety decision. Now, because this is the first time this pilot has presented with AFib, we do want the status summary because it hones in on what we need. It makes it fast for us to review, but it's limited information. So we also asked for the detailed clinical progress note from whoever saw this pilot. PCP, cardiology, internal medicine, ER. If they went to the hospital for an event, we want the H&P and the discharge summary. So that's the history that we need. We need a current cardiac monitor, something that's like a Holter, 24 hours at least. And then because it's an initial episode, we also want somebody to check a TSH. We do require a sleep study because sleep study and AFib, OSA and AFib are sometimes related. We also require an echo and a stress test. And if anybody is still taking warfarin, I know that's lost favor because the NOACs, DOACs are much more common now. But if anybody is taking warfarin, we do need the INRs. So you as an AME, you're on row C. You've made sure that this is a new episode. You have either collected or have told the pilot what information they need to collect, and then you're going to defer. First time evaluation. So this is the status summary we talked about. It's specific for AFib or flutter. As you read through this, remember it has two uses. One is it lets us quickly make a safety decision because the status summary has honed in on what questions are really important. But two, it also helps the treating cardiologist, the treating internal medicine doctor know a little bit about what we're looking for. So what we ask on the summary is, has the condition worsened in the past year? Is there any evidence of stroke, TIA, or thromboembolic event? That's important when we get down to number 4, which is the CHADS VASC score, because if they've had a stroke, a TIA, their VASC score goes up. We also need to know, is treatment indicated? Is that for rate, rhythm, or for symptoms? The CHADS VASC score, you can get these online calculators that'll calculate it for you. If not, the cardiologist can use this one. Remember on number 5, if they have a CHA2DS2-VASc score of 2 or more, they have to be on some type of anticoagulation. NOAC, DOAC, warfarin, or an LAA closure device. And then they also need a current Holter. On the current Holter, number 6 describes the parameters that we need on the Holter to be considered for special issuance. So the first one is we want to make sure that their average heart rate is not more than 100. We want to make sure that a non-exertional, they don't have it higher than 120. And we want to make sure there's no pauses greater than 3 seconds. And when you submit the status summary, you also need to submit a copy of that Holter report. We like to ask if the patient's compliant. Okay, is the pilot compliant with their treating physician? And then does the treating physician have any concerns, or have there been significant changes since the last visit? So as you can see, a lot of what you're going to see on here is already in the progress note, but different doctors write different progress notes different ways to speed up our review and to make sure that the questions we need answered are answered. The status summary helps with that. So first time with AFib, 77, third class. Initially for the AFib component, you're going to defer. These cases are all worked in what's called general review. If they're well controlled, they're potentially going to qualify for an AASI. If they're not as well controlled, they might be on a special issuance instead. Usually the certificate is going to be limited to 1 year. So let's say this pilot was placed on an AASI. Anybody who's been watching and comparing with what's in the guide or with what you already know from doing aerospace medicine, there were a couple of gaps there, right? The Holter they weren't going to have until next month. Didn't have all of the information, didn't have a sleep study, didn't have a TSH. But when the case is reviewed, if you will make sure all that information is uploaded into AMCS, we'll be able to see it on our end and make the decision. So in this specific pilot, he was given an AASI. He comes to see you 2 years later. He has his AASI for AFib. He's doing great. He brings another completed status report from his cardiologist who says, yep, we didn't need the Pradax anymore, so we switched him over to aspirin and Plavix. He didn't have a Holter again this time because it wasn't covered by his insurance company. When somebody's on an AASI and you're doing the follow-up, the question is, can you say yes? Can you give them another 1 year time-limited certificate? And to do that, you have to make sure that they're stable and that the AASI criteria are met and that you don't have any concerns as a physician. Remember, we talked about the CHA2DS2-VASc. If they have a number of 2 or higher, they have to be on anticoagulation. And that's because AFib can still cause an atriopathy. They can develop clots. The atrium can get dilated. When they get fibrillation, it's really a symptom of kind of a diseased atrium. So even if they don't have active AFib, they can still get a little bit of clot development, just at a lower rate. So anybody that has a CHA2DS2-VASc of 2 or higher is going to need to be on anticoagulation for aerospace medicine purposes. So your next question is, are they on an acceptable anticoagulant? So we talked about NOACs, DOACs, warfarin, or an LAA occluder. It's like your Watchman device. The clot rate is lower, but it can still occur. This pilot, remember on the scenario, he was on Pradaxa, got an AASI, and then in the 2 year follow-up someplace, they switched him to aspirin and Plavix. That's not anticoagulation, it's dual platelet inhibitor therapy. So if your pilot was already on an AASI and he comes back to you on aspirin and Plavix instead of a DOAC, NOAC, then actually that's one that you do not do the recertification on. So if you're going to do a checklist on this pilot, is this a new diagnosis for the AFib? Nope. Do they have a current SI or AASI? Yes. If it's an AASI, there's requirements in the AME Guide. You want to verify the meds are correct. So anticoagulation meds, not dual antiplatelet inhibitors. You want to verify that everything on the status summary falls into that left-hand column. So a lot of the status summaries are written so that if everything falls in the left-hand column, you're good. You can issue or reissue. If anything hits the right-hand column, that's the part that you have to think about or call about. You also want to verify that the CHADS 2 VASC score has not increased since they were given a special issuance. You also want to make sure that the Holter meets all the parameters in number 6. And remember, this pilot didn't have his next Holter because he was waiting for insurance. Once you have the recert information, which is usually the status summary, AFib status summary, and the Holter, you're going to upload those into AMCS. So your actions at this point, because he was no longer on an anticoagulant and you did not have a Holter, that is somebody that even though he's on an AASI, you should not issue a recert. Now, if he brings you a Holter and it meets the parameters that are listed in number 6 in the status summary, and if he is back on true anticoagulants, that is somebody who you could just do a repeat 1-year time limit certificate as long as he still has a valid AASI. All right, changing gears a little bit. So that's how we look at AFib. Aortic dilatation, aortic aneurysm, aeromedical risks, aortic rupture, dissection, or sudden death. Where can you find information on this? You can look in this presentation, or you can go to the guide and you can search aneurysm. Remember, you can get aneurysm in multiple locations. We're specifically talking about aortic. This is still in the old AME Guide platform. So it asks for all pertinent, all available medical documentations. And you, as an AME, are going, what medical documentation do you really need? So here's what we really need. We need the detailed clinical progress note from the treating physician. Sometimes it's a cardiologist. Usually when they get to be about 4.5 centimeters or larger, it's a vascular surgeon. We will usually follow somebody with an aortic dilatation, aortic aneurysm of about 4 centimeters and higher. When we get the progress note from the vascular surgeon or the cardiologist, we want them to specifically tell us about the rate of change. Is that a concern? Is surgery indicated? Any other treatment indicated? So that's what we need on the progress note. We also need the most recent imaging. Now, a lot of times, if it's just above 4 centimeters, an echo is fine. Less invasive, less expensive. We can see what we need. As an aneurysm starts to increase, it's at a higher risk of rupture. So somewhere between 4 and 5, they might need to get an angiogram, a CT angiogram, or an MR angiogram. Gives a better number. It's more accurate as far as what the size of the aneurysm is. So what to expect? You're the AME, you're seeing this pilot. Initially, you'll have to defer. These cases are all worked in general review. And because they can progress and because there is a risk of sudden incapacitation, we follow them on a special issuance. The first one you'll have to defer. And in some cases, you'll be able to do the recert, but you'll have to look at the authorization letter. There is no AASI at this time for an aortic aneurysm. So why are we following an aneurysm? And why do we ask them to get an echo or a CT MRA? Echo size is subject to technique error. As they get larger, again, they're more likely to rupture. We want to make sure that from year 1 to year 2 and year 2 to year 3, that we don't see an increase that would be concern for a rupture. So at some point, maybe 4.5 or so, sometimes we will ask for a CT angiogram or an MR angiogram. Just gives us a better measurement. These numbers are general. Remember, anything in the AME guide is general, generic. Anything that's on your pilot-specific authorization letter is for that pilot. First time the pilot showed up with this, if they have an echo report, send us the echo report. Send us the progress note from the treating physician, the treating cardiologist, or the treating vascular surgeon. If they have some type of connective tissue disorder, sometimes we will ask for information a little bit earlier. Sometimes we will follow them more closely. Depends on the rest of the underlying condition. Okay, we're going to go to case number 2. So this is a 43-year-old, second class. You've been seeing this pilot for 10 years. Their past medical history is high blood pressure treated with lisinopril and HCTZ that's well controlled. They have diabetes that was diagnosed at their last AME exam because you caught that they had 2+ glucose in their urine. Their initial presenting A1C was 7.2. His primary doc put him on metformin for about 8 months. And then the primary doc stopped the metformin and started one of the GLP-1 drugs about 2 months ago. And his most recent A1C is 5.8. So on this case, which khaki can you use? So the first khaki you know that you could use is hypertension treated with meds. On the left is the dispo table. Remember, you could go to your favorite search bar, type in hypertension, FAA, AME Guide, hypertension disposition table. This pilot was on a combination of 2 different medications. So that would be row B. Row B is going to punt you over to the khaki worksheet. Khaki worksheet's on your right. Remember, hypertension is the one where if you're comfortable, you know the pilot, you know they're getting good care, you don't have any concerns. It's the one where you don't have to have a note from the primary doctor, whoever's taking care of them. If they've been stable for at least 7 days on their med, no symptoms, their blood pressure is 155/95 or less, the meds are acceptable. There is a link to the pharmacy antihypertensive meds page. Dr. Q's done a great job of adding additional meds to the AME guide. So if you get to hypertension, you can click that link. It'll give you a list of all the different types of medication classes that are acceptable. The good thing to give your pilots or to get them to that document so they can bring it to their doctor and see what meds are allowed. So we have hypertension treated with meds. What other khaki will they qualify for? So we already said they have diabetes. They were initially diagnosed with 2+ glucose and A1C of 7.2. They were put on metformin. Then they were changed to a GLP and their A1C is now 5.8. So their A1C at 5.8 puts them in that prediabetes category by A1C number only. The problem is they were already diagnosed with diabetes. So their medical risks for diabetes are hypoglycemia, cardiovascular disease, diabetic retinopathy, nephropathy, and neuropathy. It's a small vessel disease. So where do I find the information on this? The first place you go to in the AME Guide, FAA AME Guide, dispo table, diabetes. When you bring up the dispo table on diabetes, it has about 5 different rows because there's different types, different treatment options. One of the questions that we got repeatedly on the survey was, if somebody has diabetes that's on weight loss medication, how do I do the khaki? Remember, diabetes in remission is still diabetes. So for aerospace medicine purposes, if they're in remission, their A1C is in that prediabetes or normal range. If it's because of meds, if they have to take meds to correct that, we still consider them to be diabetic. And if they require meds, there's a specific CFR that talks about that. We'll get to that in just a minute. If they have ever had an A1C of 6.5 or higher, you'll see that on both the khaki prediabetes and the khaki weight loss. In a yellow box, it says if you've ever had an A1C of 6.5 or greater, do not use this khaki. Remember, khakis, low risk, high yield, should be somebody who's very stable. That's a lot of the components to a khaki. So we get the question frequently, why can't I khaki somebody with diabetes on meds? This is the specific CFR that says for this general medical condition, specifically a history of or clinical diagnosis of diabetes that requires insulin or a hypoglycemic drug, there's a specific CFR for that. Because of that CFR, we don't have a khaki for diabetes on meds. We can do an AASI. If an AASI parameters are not met, we can think about an SI. So the trick question for today is, you as the AME, you see this pilot that we've talked about, do you use the prediabetes khaki or do you use the weight management khaki? because they're on a GLP. Everybody wants to go to weight management. Maybe they're using it for weight loss, but they're also diabetic on a GLP. Which CAC can use? And this is a trick question because the answer is neither, because of that bright yellow box that says if they've ever had an A1C of 6.5 or greater, do not use the CAC. Remember, your pilot presented with an A1C initially of 7.2, so their best option is an AASI. They do not qualify for the CAC. But while we're on the weight loss CAC right now, the GLPs are all acceptable. They're in that third row down. We did have questions this morning about when we first rolled out the CAC, we excluded anybody who had substance use disorder. We are still looking at that to see if we can take that off. Has not been published yet. But when the CAC first came out, there was a warning for substance use disorder, and that's why we excluded it from the CAC. But that was a year ago, and medicine changes over time. So look for that in the future. But right now for the CAC, make sure they've never had an A1C of 6.5 or greater. Make sure they're on just one of the acceptable meds. So if they're on metformin and the GLP, they don't qualify for the CAC. If they're on just a GLP or just metformin, they could potentially qualify for the CAC. What should you and the pilot expect next? The first thing, if this is the first time your pilot has shown up with diabetes, taking medication with a previous A1C that was above 6.5, you're going to have to defer. These cases will be worked in medical appeals, and they'll be followed either on an AASI or an SI. For AASI, you may be able to do the research. Remember, they do not qualify for CAC because CAC on diabetes is a CFR requirement. There is no CAC for diabetes because of the CFR requirement, but you can CAC the hypertension. All right, one quick slide on color vision. What went out in the last couple of weeks was a letter to a bunch of pilots that said if you had to take a color vision test and you took one and you did not pass and you submitted a request for an upgrade, those are all worked at headquarters. We've looked at all of those. We've had a small group of people looking at those. The letter that's going to your pilot says, go take that test again. Take it a couple of times. If you can't take that test, take any of the other 2 tests that are allowed. What the research found was that the CAD and the Ray-Ban are easier to pass. They're more expensive. There's not as many people that have them, but they're easier to pass. And the Wagner, sometimes you have to take it a couple of times to get used to it. Remember, if your pilot had a previous medical certificate and flight hours, even if they had a limitation for color vision, they keep what they walked in with. So if they had a second class with a limitation 17, one of the color vision limitations, as long as they walk into your office and they just want a second class again and they're okay with that limitation 17, you can still give them a second class limitation 17 if they're otherwise qualified. They do not need a new color vision test. So remember, whatever they walked in with before, they should be able to walk out with again. If they want to upgrade class of medical, or they want to remove the limitation that's required for color vision, then they have to take a color vision test. Please remember to upload your color vision tests also into AMCS so that we can track those. The other thing is, if you did not perform the test, we're trying to get some verification that the results coming in were really that pilot. So if you are comfortable that that pilot brought in their own results, if you'll sign that, we will take it. If you did the test in your clinic, you can just put that in block 60. It's your own test. You don't have to sign your own test. 2 things from this morning that I forgot. One is the Ray-Ban test. They pass at 55 and up. If you look in the current AME guide, we're still waiting for updates. It says 75, but a Ray-Ban, they have to get 55 on each color. That is a pass. If you do not know where other tests are near you, you can call your regional flight surgeon's office. They do have a short list of where some of the other tests are other than Wagner's. So just 2 points for you. All right, a couple of Other items, medications, are they allowed or not? We had a lot of questions on the survey about how do I tell if meds are allowed? Remember the risks? It's the side effect or the known effects of the meds. And it's also the condition of the stage that they're used for. How do you find meds? The first thing is check the do not issue, do not fly list. Make sure that your pilot is not taking a med that you should not be issuing, or make sure that it's a do not fly where they have a downtime after taking it. The other section to look at is the pharmaceutical section. Again, Dr. Q has expanded the pharmaceutical section. Every time she's able, we try and have her put new pages in of common meds so that you can find them, so that your pilots can find them. A lot of them are done in classes instead of individual drug names because some of the classes just have too many drugs to keep up with. Remember to look on your khaki worksheets. Psoriasis, colitis, arthritis, they're all 2-page khakis now because of the number of meds Dr. Q was able to add to the khaki. And then at the bottom, www.faa.gov/go/meds will bring you to the list of all the meds that we currently have and information for them. This is the list on the Go page. These are all the different pharmacy pages that Dr. Q's created for us. All right, we had a couple of questions about cancer. What do you do when you see somebody with a cancer condition? The first thing is just see if there's a dispo table that exists. FAA, AME Guide, dispo table, name of the cancer. Some of them are khakis, prostate, testicular cancer, breast cancer. If there's no dispo table, things to think about before submitting. They should really be in remission or their treatment's complete. There's not really specific downtime. We're trying to get away from mandatory downtimes for a lot of conditions. It's more based on how is that pilot progressing in their treatment. Is their treatment over, specifically chemo or radiation? If they're on one of the new immunologic type of medicines, what does their oncologist say? We want to make sure that they're stable. We want to make sure that there's not evidence of metastatic disease. We want to make sure that their oncologist thinks they have a good prognosis. We also want the oncologist to tell us in their progress note, how frequently do they need to see this person? If somebody needs to be seen every month, every 6 weeks, they're potentially at a higher risk than somebody who is kind of in that maintenance clinic mode. Come see me every 6 months. Come see me every year. So that's what we need for cancer. The other thing is, remember to look at the do not issue, do not fly list. Cancer treatments, for the most part, are not allowed. Part of that is because of the condition. Part of that is because of the side effect or known effects of the drugs. So let's talk about verbal offs. Because if you have a pilot who is uncomplicated, who otherwise they would maybe khaki, or otherwise you could do a research, but something just doesn't quite meet the criteria, a verbal off is where you can call AMCD or your regional flight surgeon's office for a simple case. You have all the required information that you would otherwise be able to issue. That's a good case for a verbal off. When not to use a verbal off, new pilot. So if there is no AMCS file, there's no DIWS file. We don't have anywhere to put a chart note. So if you call us and talk to us about the pilot that you have in your office, that there is no electronic medical record on our system yet, we have nowhere to put a note. So it would be equivalent to you working in the ER or in your clinic and seeing somebody with no chart. So because there are hundreds of thousands of pilots and a lot of them have very similar names and or birthdays, if we don't have a chart, we have nowhere to put that decision and nowhere to put that information. So we don't do verbal offs if it's a new pilot. Another reason that we would not do a verbal off is if there's a new condition, something that's complicated, the change in a condition, something that is going to need more documentation or it's a higher risk. The other thing is if you don't have all the documentation, we need that documentation to be able to make the decision. Again, AMEs, you guys are the eyes and ears of the FAA. If you're looking at this pilot and going, nope, would not certify that pilot, and the pilot is bothering you and asking you to say, hey, call the FAA, call the FAA, you can call the FAA. You can tell us that history. Then you can go back to your pilot and said, I called the FAA and they said they would get to it. But if you have concerns about the pilot, that's one place that you can let us know, Block 60, or if you talk to us. And the other time that we don't do verbal OSS are conditions that are more complicated. A lot of them go to panel, cardiology conditions, neurology conditions, and drug and alcohol. So good times to use verbal OSS, establish patients, maybe a small change in condition where you're not quite sure if they would be able to continue their AASI or not. You've got all the documents and you would be fine issuing. Steps to completing a verbal OSS: upload the information you have into AMCS. You can even put it in the old exam. That way, when you call the FAA physician and you're speaking, we can see the information that you've provided. Remember, if the exam's less than 14 days, you can call AMCD or the regional flight surgeon. Sometimes they'll give you an off and you can go ahead and issue at that time, not for a new pilot. If it's been more than 14 days and you already transmitted the exam deferred, and then you get the new documentation and you upload it and you think it's a very easy case, that's another scenario where you might be able to call for a verbal auth. In that case, we would have to pull it from our end. All right, and with that, we have a couple of minutes left. This is our shameless plug for how do we improve the AME guide. If you have suggestions, please use this address. And thank you for all your time.
Thank you all for coming tonight. We really do appreciate your help. We could not do this without you. And Dr. Wyrick, I see you on camera. Would you like to say a few things?
Yeah, I'd just like to tell everybody, thank you for your interest in aviation safety and thank you for being aviation medical examiners with us. We know that sometimes going through the bureaucracy can be frustrating. Believe me that Dr. Northrup and I are working constantly trying to get the resources necessary to make your lives easier. And speaking on behalf of Dr. Northrup, you know, from the moment she gets up in the morning till the time she goes to bed at night, it's all about aeromedical certification and how do we do it better. And just one other thing, I tell this to the FAA employees all the time, but when you look up in the sky and you see a contrail, you had something to do with it. Thank you for your help and thank you for hanging in there with us. We appreciate it. Over.
Okay, thank you all for coming. This concludes this evening's session